Vad roligt att just du har valt att lyssna på vår podd. Tillsammans kan vi skapa större möjligheter för förståelsen för integrativ medicin och hälsa. Är du intresserad av det så bli gärna medlem i vår förening och en del av vårt nätverk. Mer information om det här kommer i slutet av avsnittet, men du kan också redan nu hitta det på vår webbsida integrativ-medicin.se. Jag som leder samtalen heter Lena Källqvist. Jag är ordförande för föreningen som driver den här podden. Min yrkestitel är legitimerad psykoterapeut med grundutbildning legitimerad sjuksköterska. We are now in sunny Washington. We have this integrative mental health conference that we are in, me and Dr. Cecilia and Dr. Sharam Lavasani. And we are sitting outside, and maybe we're going to be interrupted with some noise, and we just handle it. We are 3 women here, so we handle everything. So if the listener is hearing something that is disturbing, it's just going to go away or in a couple of seconds. So, welcome to the podcast, both and either of, podcast of integrative mental health care. And today we have a special guest. We are so honored to have medical doctor Felice Gersh. Right?
Gersh. So
Gersh.
Close, yes.
Sorry, my bad. Felice Gersh. That is a multi-award winning physician with a dual board certification OB-GYN and integrative medicine. You're also the founder and director of the integrative medicine group of Irvine, a practice that provides comprehensive healthcare for women by combining the best evidence-based therapies from conventional, naturopathic, and holistic medicine. You received your education at Princeton University, USC School of Medicine, Kaiser Hospital, and University of Arizona School of Medicine. You received the highly coveted, do you say so? Coveted Outstanding Volunteer Clinical Faculty Award. We talk about all this and maybe more. While teaching obstetric and gynecology at Keck, do you say Keck? USC School of Medicine, where you served for 12 years as assistant clinical professor. You now serve as an affiliated faculty member at the fellowship in integrative medicine through the University of Arizona School of Medicine, where you are a mentor and regularly grades the case presentation written by the fellowship student for the final exams. And you are the best-selling author of PCOS SOS and PCOS SOS Fertility Fast Track and Menopause, 50 Things You Need to Know. And you have also numerous scientific articles published in peer-reviewed medical journals. And you are a prolific, how do you say that? Cecilia.
You said it right.
Yeah, lecturer, and has been featured in several films and documentary series, including The Real Skinny on Fat with Montel Williams, Fasting with Walter Longo, PhD, and The Business of Birth Control. My God, we have a star here next to us. You're so welcome.
Well, I'm thrilled to be here. This is really an honor to meet you and then to participate in your mission, which you explained to me before we started, which I am just so in awe of what you're doing. So if I can help, that's why I'm here.
Oh, thank you so much. And we have also Dr. Cecilia here, Cecilia Tibell, that is going to lead this conversation today. We're going to have this conversation. And we're also sitting outside. So if it's a little bit windy or, here's something about that, why.
Well, I think also for us sitting outside in the middle of October is sort of nice. Back in Stockholm, it's now getting a bit rainy, grey and chilly and dark. So this is really nice. But I'm really happy to have you in this podcast, Felice. I think I heard you first time 2019 in this exact conference, and I think, correct me if I'm wrong, part of your mission has been to make people understand how important our female hormones actually are for our health.
I know, it seems crazy, doesn't it, that you have to go around and basically just beat the drum in favor of hormones. It's like a natural, beautiful part of the body, and it has all these different activities and receptors and mechanisms and functions. And why would it even be debatable? You know, this is like a fact that these hormones that women make from their ovaries are essential for optimal health. So I'm just really, what to me seems like stating the obvious over and over, but if that's what it takes, then that's what I'll keep doing until it becomes widely recognized worldwide that these hormones are not just sex hormones. They are hormones of life itself. They help create life, but they also are essential to optimize health and life for the duration of that woman's existence on this planet.
Well, I couldn't agree more. And I think I told you that in Sweden there has been a debate, and unfortunately I think that the voices that are loudest are sort of against this discussion. And I always say that if men were given birth control pills and menopause treatment the way we treat women, they would object. That would never ever happen. We wouldn't have synthetic testosterone. We would have of course, we have the bioidentical hormones for men, which is testosterone. But with women, we have a discussion with bioidentical hormone. And I think part of the problem with the Swedish OB/GYN society is that they are so focused on the endometrium and how thick it is or not, that they sort of that's the only function of progesterone, which both you and I know it's not. So would you care to explore a little bit about why progesterone is important?
Well, progesterone is probably the most under-recognized hormone of all. I mean, I talk about estrogen not being given its due and its respect, but progesterone even less so, because it's the same thing here in the U.S. that the medical societies say if a woman is on hormones and she has had a hysterectomy, so her uterus has been surgically removed, she does not need to take, not only does she not need to take progesterone, it's like she shouldn't take it. It shouldn't even be like offered. It's just not even on the table. It's not like it should not be done. And that is about as narrow a view of a really important hormone. There's not one entity, one chemical in the body that does one thing. Like every enzyme is functioning in multiple sites, every peptide functions in multiple sites, every neurotransmitter and every hormone has a multitude of receptors and effects in the body. So to think that progesterone has one and only one mission, which is to control the lining of the uterus, and of course its involvement in pregnancy, and that's it. That is absurd. So progesterone has so many beneficial effects. If you look at the neurological system alone, so when it comes to nerve health, and nerves of course are critical for every organ system is innervated by nerves. The myelin sheath, that's like the covering, it's like insulation if you had a wire, you know, so like that covering of the nerve is maintained by progesterone. It helps to create a calmness in the brain, so that it's actually been shown to reduce seizures, especially as people age, like they call them senior seizures. And when they've done studies in terms of brain trauma, it is neuroprotective. In terms of the immune system, it is generally speaking anti-inflammatory. And it has these really interesting effects on the system in the body called the endocannabinoid system, where it downregulates the endocannabinoid production and in ways that are essential in different parts of the body and different timings of different like cycles and so on. It's sort of like a little bit the opposite of estrogen in some ways. They work like a team, and sometimes like in terms of certain things, estrogen is like the on switch, progesterone is the off switch, but they work in a beautiful, like cohesive, like symphony. And if you just have estrogen and you don't have progesterone, there are significant issues in terms of like a menstrual cycle. When you have progesterone that comes and goes, it's only out for 2 weeks of the cycle. If it's a 4-week cycle, there's 2 weeks with progesterone, and it has effects on the receptors. Like it will downregulate testosterone receptors, so they're like less active, and it downregulates estrogen receptors, and then in turn estrogen in the form of estradiol, that's the form that's made by the ovary, it upregulates its own receptor, testosterone receptors, thyroid receptors, progesterone receptors, and then when progesterone drops off, if there's a menstrual period and the woman's not pregnant, there's like a reboot to these receptors. So there's so many ways in the body that progesterone is so important for gene expression. Tumor suppressor genes are activated by progesterone, and we know that it's in the bone, it's in the skin, it actually rejuvenates skin, it's good for the musculoskeletal system. So it's ridiculous to say if you don't have a uterus, then progesterone is unimportant or useless. It's a really important hormone.
Yeah, and I find, I see a lot of women, and I'm an endocrinologist, I'm not a gynecologist, and I always say that you need to see the gynecologist to do the checkup, but we can discuss the hormones. Because I know this problem with in sort of the average gynecologist, and they will even be provoked by patients saying, but I would want my own hormone. I would want the bioidentical part of the hormone. I would want to be as natural as possible. And for me, it's always been very hard to understand in this discussion why the hormones that we produce ourselves would be a problem. I mean, we produce estradiol, we produce progesterone. We don't produce estradiol. I mean...
Well, I'm glad that you brought that up, because it's almost in women who do have a uterus, and they say if you're on hormones, then you should have some counter to the growth effect of the estrogen on the uterine lining. But they talk about these chemicals, which have been named, a fake name, it's just a man-made name, called progestins, right? So these are chemicals that never exist in nature, never exist in a female body, and technically they're what we would label progesterone endocrine disruptors. So they act on the receptors for progesterone, and often very powerfully in the lining of the uterus, more powerfully than natural progesterone. But when you go to other organ systems, it can bind to the receptor, and whereas in the uterine lining, it's an agonist. It turns on the switch, just as if real progesterone were there, but more powerfully, so it's not really the same natural effect. But when you go to other structures, like, say, the brain, the arteries, the breasts, and so on, it can have an antagonistic effect. That's sort of what endocrine disruptors do. They don't function the way the natural hormone does. So they can actually act as a blocker to real progesterone in those organs. And of course, if you use them in terms of like a contraceptive, you're shutting down ovulation, and you're shutting down all the natural production of hormones from the ovary. Like you said, these are not human hormones. They're endocrine disruptors. Technically, it's not, it sounds crazy, but it's not totally different than if you lick plastic. That are also, endocrine disruptors. It's just either like controlled endocrine disruptors. But it's important that women who understand this can be respected. And if they say, I want bioidentical progesterone, or say, why are you giving me this alternative chemical? Why are you not giving me the type that is naturally made by my body? They should be respected.
Yeah, I also think we have a system for the breakdown of these hormones, and then of course I would say that some women I find have problems with tolerating progesterone when in menopause. I find very often a correlation with when I ask them how was your pregnancy, they say I had a lot of problem with nausea, I was vomiting a lot, it took almost 20 weeks to get to a point where I felt well. And those I find are the women who normally also complain a bit more and feel maybe not so good on progesterone. So what's your advice to these women? Because a lot of them would want the natural, but they sort of...
I look at what their symptoms are. The most common complaint that I get is that the oral progesterone, which has metabolites, so it's metabolized into other products through the digestion and going through the liver because it's taken orally, some of these metabolic byproducts can sort of increase the production in the brain of the neurotransmitter GABA. It's sort of a down regulator of the excitatory system of the brain. It kind of like is suppressive. So you feel more sedated, sleepy, but for some it's too much and they feel like I'm drugged. I'm like sleepy all the time, or I feel wobbly, or I feel like I'm lightheaded. And in those women, we have to look at, well, maybe if you start having those symptoms in the early morning when you wake up and it sort of continues, how long does it continue? Does it continue all day or for the first 2 hours? Sometimes for them, you can take it earlier in the evening so that it's metabolized and kind of the effect, that sort of sedating effect is worn off by the time they get up. In some cases, that may not be acceptable, that no matter what we do, it's just not going to work for them.
Yeah, I normally recommend try to take it vaginally then.
Exactly, I was going to say, you got to take it not orally then. Exactly, we're thinking the same. You got to get it in through some sort of skin entrance. It possibly could be vaginal, it possibly could be dermal through a different area of the skin, but and then you're going to have to sort of watch how it's absorbed and so on. But you just can't give it orally, because generally speaking, if you give it in another modality, not orally, you don't get those effects. And depending on other effects, it might be the commercial product is in the oil of a peanut, so it's peanut oil. So some people may not react well to peanut oil, and if it's made by a compounding pharmacy, which we have available in the U.S.
We don't.
Oh, well.
We have Besine, that's what we got, the German company who's been doing this for 25 years. They're very good at it because they only work with bioidentical hormones, and they've done it from the start. So it's, as a pharmaceutical company, they are going natural. They have an estradiol gel that I use myself, and they also have a testosterone product. Not, unfortunately, no one adapted to women, because I find that some women actually do need a little bit of testosterone, not much, but a little bit, and then there's no option today. We used to have an option, but there's no longer an option.
That is a problem. Yes. So we have just a few different options in terms of progesterone. We can have it derived from peanuts, or instead derived from yams. And for some people, those make a difference. Do you have progesterone cream? Or just intravaginal gel or cream?
Intravaginal gel I sometimes use.
Yeah.
And we have a vaginal suppository that you can't swallow as well. The indication then is for pregnancy, actually. Yeah.
We have the same thing here.
Yeah. So, and I talked to this pharmaceutical company because in other parts of Europe, it's nothing strange to work with bioidentical hormones, and they actually have the indication treating menopausal women with, but in Sweden we don't, and I think, but I usually say when they take it orally, if you wake up feeling like you've drunken a bottle of wine, we need to do something. Because that sort of sums it up. You have a little more anxiety, you feel like groggy and still drugged and tired and sleepy and maybe a bit nauseous. And
Well, I agree. And when I prescribe, I want it to be successful for the life of the woman. So no one's going to put up with that. And it's not even probably safe, if they're going to drive or like cook and so on. But so, I play with it a little bit, but if it just is not going to be suitable, then we have to do these other alternatives.
And then what would you do? Because I find that when I've tried all the solution, I go to dihydrogesterone, I think. It's called Difastone in Swedish. But it's a licensed product, so...
Well, we have you may have the same one. It's called drospirenone, That's our name for it.
Yeah. That's the same. It's the same stuff.
Oh my goodness! All right, we're doing the same thing. Okay.
Yeah, because that's the closest to progesterone.
Exactly. Oh, see, we're clones. Okay, so exactly, it's a derivative of spironolactone, and it is absolutely the closest to progesterone. It doesn't have any androgenic effects because it's not derived from 19 nor testosterone. It's derived. It's a unique one that's derived from spironolactone and has a very pure kind of progesterone receptor function. So it's not the same, but when you run out of other options, it's a reasonable substitute because we have to do something.
Yeah. So, but also you mentioned bone health. I'm going to go into these hormones because I really think people need to understand, and I want to advocate for the population to be informed.
Can I just ask one question? Is it so that every woman have these effects on progesterone? Thank you. Is it that every woman has these issues with it? Can have, or is it so that the
Fortunately, no. In fact, the majority, I would say 95% of my patients love their progesterone. Yeah. They love it so much they hate it if I take it away. They say, I get the best night's sleep, I feel rested, exactly. They feel fantastic. But like so many things, there is this 5%. For my practice, it's about 5%. Yeah. But, those 5% are substantial in terms of their problems, their difficulties. But fortunately, it's not the majority at all.
No. But is there women that doesn't feel anything?
I would say, there's some women that say, I just feel okay. I mean, they don't feel like they have better sleep. They don't feel groggy. They just feel normal. But I would say the majority of my patients like it. I would say,
yeah,
because many women have some sleep difficulties, so they like it.
So now Dr. Sharam Lavasani came into the conversation. So now on the diary, how do you think anything about the diary for the menopause?
Do you mean the dairy, the milk,
the
cow products?
Oh, okay.
Not the diary.
Well,
sorry, my bad.
Dairy. How do you say it?
Oh my God.
So I am not in general a fan of dairy, but particularly in the U.S. because the way that cows are cared for is, first of all, inhumane. Second of all, they keep them pregnant almost all the time. Right. So the milk is actually from cows who just had a birth and now they're already pregnant again. They just keep inseminating them. And there's all kinds of growth factors and often antibiotics. And it's just, because it has to be pasteurized because it would not be safe in this country to have it not pasteurized. It'd probably be all full of salmonella and E. coli and all these bacteria. The whole probiotic issue is gone. There's nothing like that. And so you'd have to ferment it and turn it into, kefir or yogurt, but you're still dealing with the same base product. So if I have any one of my patients have a dairy product, I say, have a small amount of cheese, European, from the best sources, and just a little bit, not too much. No. And if you really, really want to have some yogurt or kefir, then make sure it's full fat, organic, the best you can possibly get. But in general, I discourage a lot of dairy. In fact, there's been some data that, especially in childhood, like heavy milk drinking actually increases the lifetime risk of cancers. Maybe, but they do tend to grow taller. So as you can see, I'm quite a short person. So I actually never drank. I never liked dairy products or milk when I was a kid. So for better or worse, I am quite short, but I don't have all those growth factors in me that weren't appropriate. So
I also think that normally when we were kids, if you listen to yourself, you know what you need. So if you said that you didn't want dairy products and milk, that was probably correct. Right. I mean, that was would be. But going back to the hormones,
this was an introduction to the bone health.
Yes, because with progesterone and bone health, I also find that a lot of times, I don't know about your experience, but you get women that come to you and they are on SSRIs, and they are on sleeping pills, they are on painkillers, they are maybe on hypertension drug, and even worst case, because they have hypertension, then suddenly there's an indication to start them on a statin, which is sort of just an example. I had this woman coming to me, she was around her 50s, very obviously perimenopausal. She had all the symptoms, and I think the problem is that it's irritability and hot flashes, and then nothing else. But she didn't have much of that, but she had joint pain, she had muscle pain, she was tired, she didn't sleep, her blood pressure was up, she was not well medicated with her thyroid, and losing hair. And all I did was to put her on bioidentical hormones and change her thyroid medication to desiccated thyroid. And then I saw her a few times, but about a year later, she was 20 kilos less. We took away the gluten, we worked with the diet and the integrative approach. And the only medications she had left was her menopausal treatment and her thyroid medication. And I think that this is why we need to talk about this, because it's like we don't recognize all the menopausal symptoms.
Right. That is absolutely true. Once you acknowledge, and this is not like widely acknowledged and understood, that there are receptors for these hormones in every organ system. So when you have an insufficiency, which is what happens during the transition or the perimenopausal years, and then ultimately a true deficiency when the ovaries cease to make any of the estrogen or progesterone, you can have manifestations of these deficiency states in any or all organs. So it just happens that different women will express different symptoms, but they're equally from the same origin, which is an insufficient amount of these really important hormones. So in some women, it's the heart that seems to be the dominant one. So they'll get really terrible palpitations. In others, it's the brain. So they have brain fog, is what we say. You know, like they can't remember, especially nouns. They can't remember the names of things. They can remember adjectives and verbs. So it's like playing charades. Like they can describe everything, but they can't remember what it's called. Like, where was I? What was the name of that place? Or what, you know, who is that person? But she wore a red dress. And they can describe it, they can't name. And they may also have mood disorders. So once, and we're here at a mental health conference, when women are transitioning, women who have never had a history of any mental health problem at all, right away, their risk of anxiety and depression doubles. And if they have a prior history like premenstrual syndrome, postpartum depression, or just generalized anxiety, you know, all these different issues, their risk goes up fourfold as soon as they're going into this transition. And so that's why there's this avalanche of prescriptions in the women in their 40s. In the US, there are new onset prescriptions for antidepressants in 25% of women. And it would be more if more went to get treatment, because not everybody looks for treatment. But even with just the percentage that seeks treatment, 25% of women in their 40s in the US are on typically an SSRI or SNRI.
Right. And
this is problematic.
Yeah, it's problematic. And we have it the same in Sweden. And we are might be the worst of that, because in my reception, I have a lot of women that comes around the 50s, and they are SSRI, and they come in and they doesn't have any effect of the antidepressant medicine, and they come to me, and they kind of we try to start to do psychotherapy, but I always, because I'm a nurse in the bottom, and I always have a lot of, and you know, I talk to my patients, and you can see that the lack of hair, the mood issues, they can't sleep at night, and so I reckon this, and then I send them to Cecilia, and they get treated. Great. So they might have been on antidepressive for 1 or 2 years, and they come to Cecilia through me, and they are cured for
That's
4 weeks.
That's fantastic.
Yeah, and
It's
I mean,
catastrophic that it's so many, that is so severe.
Right, and they're not all coming your way.
No,
so the
right,
ones that come to
right.
you, they get the good treatment.
Right.
But the others, no.
And you also normally look at nutritional factors. You are, I mean, if they don't see me, you normally say, you know, we have these laboratories that offer a widescreen. Do this testing, and then we look at it to see if there's something you should work on. Yeah. But I mean, we had a typical case with a woman who had been struggling for years, and she actually had a history of a lot of menstrual problems where no one ever really approached that. No. And you saw her, and she was on SSRI and sleeping pills, and but you just felt, you know, this isn't psychiatric. Something else is.
Or if it is, I want Cecilia to check her up first, because I can't do psychotherapy for years. No, and she might have some. She has to go to a gynecologist or to Cecilia to get estrogen.
So we started her on estradiol and progesterone, and 2 weeks later she called Lena and said, "I don't know how much I need to see you."
Yeah, well, that's the beauty of it.
But then she had a trauma with this, because realizing that so many years no one had even thought of this.
She had been on antidepressive medicine.
Yeah, she had so many regrets.
For all her life.
It's unbelievable. And, you know, it's in functional medicine, which is sort of like underlying a lot of the treatments. When you talk about like root cause medicine, then what you want to find out is, why are these symptoms happening? Right. You know, is it nutritional? Is it hormonal? And then you address those instead of just jumping right into like a pharmaceutical, like, you know, is most commonplace. And you also touched on a whole bunch of other symptoms, like, because it can be any organ system, it can be joint pain. You know,
and I find it's kind of common.
And
they
common.
think they have a rheumatoid disease, and could this be a rheumatism, or do I have? And I'm like, okay, let's just start this treatment first, and then we see what happens with the joint pain. And very often, I mean, estradiol is anti-inflammatory, and
yeah. And another thing, before menopause, women have far less what's called GERD, gastroesophageal reflux, where you have like the heartburn. But after menopause, women have many more cases than men. And so many women don't know why they're having all these digestive problems, and they often will have exacerbated constipation. So a lot of gut problems will happen. And then you alluded to sleep. You know, like, sleep becomes a horrible problem for so many women. And like you mentioned, they're on sleeping pills. And that's what our mission is, to realize that all of these different symptoms can have one cause. So women think, what the heck is happening to me? Like, I'm having all these symptoms, like we named, you know, problems with sleep and mood and digestion and joints, and then often, like you mentioned, hair loss, because when you have less estrogen, the sex hormone binding globulin goes down, so you have more what's called unbound testosterone. You're not making more necessarily, although that can happen too because of higher luteinizing hormones coming out in the beginning, but you have less bound testosterone, and even a tiny bit that's less bound is free to act on the tissues and can give you the androgenic alopecia. It's like the female version of male pattern baldness. And 50% of women, as they transition into menopause, see their hair thinning. And it's like so distressing for women. And then just talk about the skin. The estrogen is so critical, and progesterone too, for maintaining collagen and hyaluronic acid and the ceramides, all the different structures of skin, even like the support fat that gives you like cute little plump cheeks so that they don't look all hollow and then, you know, wrinkly. So women look in the mirror and they see, oh my gosh, my skin is aging in front of my eyes, like dry skin and dry eyes, and dental changes like gum inflammation, periodontal kinds of problems, vaginal dryness, loss of libido, you know, which is essential for people having a happy life and marriage. And then they say, I don't care, like, what my husband is so unhappy, you know. And most people don't realize that sex drive and sexual response also, not just testosterone, depends on estrogen as well. Right. So it's like a host of things. And poor woman thinks like, everything is going wrong with me. I mean, clearly, I have psychiatric problems, which they may have, but it's from all of these other problems. So it's so important to realize that it's not one woman being unlucky 20 times with 20 different symptoms. It's loss of these hormones that's creating 20 different symptoms.
Yeah, and I think with age, I mean, we lose our hormonal resilience, because when we're 20, 25, we are on our peak, sort of up to
Absolutely.
30, and we have this resilience, we have this immune resilience, we have this, stress resilience, we have these hormones. They're anabolic and they keep us strong. So when we lose them, we lose our bone, we lose our muscles, we lose our thinking, we lose our nutrition, we lose our metabolism. There's so many effects if you look at it, and it's just so sad. And I think then going back to the problem and then starting with these synthetic drugs, fortunately nowadays most birth control pills, as well as menopausal hormone treatment, is estradiol, because it used to be that we could get this horse estrogen, which is not ours. It's
actually very different. It has different compounds that have estrogenic effect, but they would never be found in a human. That's absolutely right. And like you mentioned, the immune system, that is a very critical part of the body. And the immune cells all have receptors for estrogen and progesterone. So they alter their function when you don't have the right hormones. And the body naturally goes into a more pro-inflammatory state, which of course underlies cardiovascular disease, increases insulin resistance and diabetes, and all these metabolic ills that are considered problems of aging. But I see them as problems of deficiencies that are essentially coming from the initial deficiency, which are these vital hormone deficiencies. And then it changes how the gut works, because you're changing your gut microbiome, you're changing the motility of the gut because the autonomic nervous system is altered. So you have poorer digestion, and then you end up with nutritional deficiencies. So it just kind of snowballs.
Yeah, and also we get an imbalance with more estrone, and estrone has
right.
more of a pro-inflammatory, and it's
Absolutely.
produced by the adrenals, because of course our body is trying to correct what's wrong.
Well, I'm so glad you brought that up, because so few people, even doctors, think of the different types of estrogens. They think estrogen is estrogen, and they don't distinguish, well, is it estradiol? Is it estrone? Is it estriol, the dominant one that's in pregnancy from the placenta? And they have different effects on the receptors. So they're in the same family, but they're actually have different effects. And when people talk about estrogen, what are you talking about? Is it postmenopausal produced estrone that has nothing to do with the ovarian production?
So I would like to just, if it's okay with you now, then when Dr. Sharam Lavasani came here, he is a doctor in immunology, as we say in Swedish.
Immunology.
Fantastic. And we just gave a great intro, right?
Yes,
Immune system.
So, right. And the gut-brain axis. He is also one of the persons behind the diagnostic name of, and now we have the garbage man here again. So, but we love the garbage man that takes away the garbage. We don't want to have them. So, love and light to him, but he's kind of noisy. So, but then when you came in here, we are sitting here, 3 women, and you're a man. And you're a very knowledgeable, kunnig man, as we say in Sweden.
Knowledgeable. He's very knowledgeable in the gut microbiome, where you've done a lot of research.
Yeah,
he has his PhD.
Right.
He's an associate professor of immunology, and has worked a lot with research surrounding degenerative neurological diseases, as in MS, ALS, but also chronic fatigue, where we found each other to start with, because on an Emmy conference.
Right. So I will hand this mic over to you because I think it's very interesting to have a man's opinion and a very knowledgeable man about this. So you have been listening to us. You came with our tea and some oat milk, and now we just take you into this conversation. What do you think?
First of all, it's a great honor to speaking with you, Felice. And I have heard so much about you and your. Also, I know some of your patients in California that they just talk a lot about you. So it's a great pleasure for me. Just
thank you.
Here, speaking
it's a pleasure. Likewise.
Thank you. First thing actually just came in my mind is working with the autoimmunity for many years. Why women are more prone for autoimmunity, and what you mentioned right now regarding the disruptions of the hormones, it just reminds me about the disruptions of the gut microbiome and dysbiosis. So, and what I just was thinking, imagine the fact that we are treating so many women. I mean, we are not talking about the age. I mean, mostly young women, they suffer from autoimmunity from very young age, but nobody really measure the hormones. Everybody just say, you have inflammation, let's give you a huge amount of anti-inflammatory medicines and just increase the dosage of this over and over and over in order to suppress. But are we doing it right way? Should we also take a look at the hormones? And as long as there are disruptions of the hormones and they are causing the inflammation, as you mentioned very nicely, that there is a receptors and immune system is very much associated to these disruptions. So we never go to the cause, but we're just suppressing this consequence all the time while the disease is going on and going on. So do you think that we should really combine such a diagnosis and therapies?
Oh, absolutely. If we look at the most common endocrine disorder of reproductive aged women, which also happens to be the most common cause of infertility, it's polycystic ovary syndrome.
Right.
Now, they have very significant hormonal imbalances. And back in 2015, the first studies came out of China that showed that there had been hypotheses, but then they actually proved it, that the gut microbiome is very dysbiotic or abnormal in women with PCOS who have these abnormal hormones that are circulating, too much testosterone, not enough estradiol, and sometimes high amounts of estrone because they have all that inflammation, which is upregulating the aromatase in their fat tissue, which is producing more of that estrone from predominantly the adrenal androgens.
Yes.
So they have all these problems, and we do know they have a very significant incidence of Hashimoto's thyroiditis, right, much higher than the average female population for the same age group. And so that alone is like saying, yes, hormones matter for gut health, and then gut health matters for autoimmunity, and so does the status of the immune system itself, because the immune system is, for example, very circadian. It's like very much in the rhythms, and we know that when you have problems with your hormones, which happens in women with sort of, you might say, the signature disease of hormonal imbalance of reproductive age women, the polycystic ovary syndrome patient, and then of course the women that go into menopause, that they all have what I call a life of jet lag. We know that they have circadian rhythm dysfunction. In fact, there was a study that showed women with PCOS have a flipped circadian rhythm for cortisol. Instead of having high cortisol in the morning and then low at bedtime, it's exactly the opposite. And that happens also in women when they're in perimenopause, and it upsets their entire digestion. They often have appetite dysregulation, and they can't sleep. You know, though they say I'm a night owl. Well, you're not an owl. You're not nocturnal. You know, so there's these huge things because there are estrogen receptors in the brain and the suprachiasmatic nucleus that is the master clock. Yeah. So the whole master clock, we use the word drift. It doesn't. So every day it's supposed to reset. It does not reset. So all your organs are working in different time zones. So that's metabolic chaos that ensues. So absolutely, we should be looking at the hormone levels, the production, and looking as much as you can at how are they metabolized. In fact, metabolites of estrogen are very important, and that's another thing that can be looked at. Some can be harmful, some can be really beneficial. In fact, in muscle tissue, and particularly the heart, there actually are receptors that actually bind to metabolites, like 2-methoxyestradiol, a metabolite of estradiol. That's how important real hormones are in the right amounts.
Exactly.
And then everything goes into that sort of chaotic phase, with perimenopause, where the immune cells become more activated. Like because they don't have the estrogen that they need in the body, the estradiol, they have, like I call it, a lower trigger to producing their pro-inflammatory cytokines. So it takes less of an incentive or something that triggers them, like endotoxins coming through a leaky gut.
Exactly.
That is kind of like commonplace. So you end up with, it's like one thing upon another that increases inflammation, dysregulation of the immune system. You have particles and bacteria, microbes and such, viruses coming through the leaky gut into the body proper, where the immune system becomes activated. That can lead to mistaken identity, like molecular mimicry, that can lead to autoimmunity. So it's complex, but it's absolutely ignored, like the underlying issues, so that we can actually be proactive.
Yes, and I think, I mean, if you look at autoimmunity per se, if you take away PCOS, it's also, when does this occur in life? So the young ones, they do that. It's in puberty, where you have just by starting up menstrual cycles, sort of a period of very dysregulated hormones until you find your balance. And the second time that happens is just after pregnancy, because during pregnancy, actually, autoimmunity and autoinflammatory diseases actually go down, because with those high levels of estradiol and progesterone we have at that time, we are supposed to be able to harbor a fetus without having a host graft versus graft reaction.
Absolutely.
But then after pregnancy, everything goes down. And that's when you get your postpartum thyroiditis, your Hashimoto. And then the next phase is when we start getting into this perimenopausal time. That's when we get the depression suddenly. That's when we get the autoimmunity, and because of lack of hormonal resilience. And I think we, like you said, we totally underestimate the importance of this and investigating this. And they have done, I know with microbiome, they have done rat studies looking at female rats with autoimmunity. And they did fecal transplants from male mouses. And when they were given their microbiome, they healed. Wow. Which is rather interesting, I think.
So
Very. Yeah, but that's interesting. If you put a male microbiome in a female, she'll start making more testosterone. It's like a fascinating thing. And testosterone is actually more of an, this, of course, more than I even, it's more of an immunosuppressant.
Exactly.
So that's, which is good and bad for males. So they have less autoimmunity, but they're not as good as surviving sepsis.
And not even cancer.
And cancer as well. So everything has its dark side and the silver lining.
Dark side of the moon. But we hardly have we talked now about progesterone. What we haven't talked about estradiol, which I mean, I've listened to Felice a number of times, and I'm always amazed how many sort of things you can find to talk about when it comes to estradiol. And last time I heard you lecture, tomorrow you're actually going to talk about the gut microbiome, I think, a bit, right?
I am. It's a lot of what you sort of touched on, the gut microbiome, the autonomic nervous system, estradiol, and mood, and how that all connects.
Really looking forward to hear. Coming back to the microbiome, there are a lot of discussions about, once we discover the dysbiosis, where does it come from? Is it a cause or a consequence of the diseases? So hearing your talk right now and this conversation, so could that be that the disruption of the hormones in many cases could be the cause of the dysbiosis, which in turn can have an impact on the immune system? Do you think that could also be the case, rather than microbiome disruption could have an impact on the hormonal changes, and in turn you will have the disease? So what I want to my point is that we talk about many years of research in autoimmunity in particular come to one conclusion. For most of the cases, it's not the genes, it's the environment. So how does that environment really have an impact? So could that be the fact that environmental factor might have an impact on hormonal balances, which in turn a disruption in hormones could disrupt the dysbiosis or gut microbiome, which synergize with any kind of pathology?
Well, absolutely. In fact, I'm going to touch on that in my talk tomorrow. Because if you look at the autonomic nervous system, which controls the gut motility and so many different factors, so it's like the chicken egg kind of a thing. So, or what we might say like bidirectional or multidirectional. So if you have a problem that occurs to the gut microbiome, so say it's chemical toxicants that are in food, which is kind of prevalent, or the water supply, what we consume can have such a huge impact on the gut microbiome. But so can infections. Like people can get different types of gut gastroenteritis and they could be both viral, which has been now shown with like COVID that can create all kinds of havoc, and of course other things like hepatitis and so on. And so you can have a viral gastroenteritis of some sort, and then the gut microbiome is disrupted. That will lead to impaired gut barrier and leaky gut, and that creates a pro-inflammatory state, and the ovary itself can become inflamed. In fact, they've done studies where you can pull fluid out from around the egg, the oocyte, and it will be full of inflammatory cells, which is going to definitely impair how the egg quality and the production of the hormones. We know that inflammation in the body, which then becomes a common problem in people who have leaky gut like that, from the causations that are not related initially to the hormones. But when you have high levels of inflammation in the body, progesterone production is diminished. So you'll have less production of the progesterone, you'll have poor ovulations, you'll have poor quality eggs because of the inflammation. And then the inflammation also affects the brain, where you have the in the hypothalamus, where you have all the peptides that are triggered, through these different actions, and so you have abnormal peptides like the kisspeptin, so you don't have the proper triggers to the pituitary to put out the proper sequence and levels of the gonadotropins, follicle stimulating hormone and luteinizing hormone. So then that will create disarray of the hormonal production from the ovaries. So absolutely. And then it just becomes like what we call a snowball effect, because then when you have less proper production of hormones, it exacerbates the system, and then it just gets worse and worse. And then in some cases, you may not know which came first. I mean, because you may not know until 5 years later, and the person forgot all about that they had that bad gastroenteritis. They don't remember. Exactly. Like we know that women who have a pretty significant gastroenteritis, something like 10%, it's like shocking, will develop chronic irritable bowel syndrome, which is, of course, now we know it's like SIBO or overgrowth of bacteria or fungus, and often accompanied by leaky gut and all these problems, and they don't recover, and then that's going to lead into all these other problems as well.
Right, and I think just this COVID pandemic really showed that, because so many hormonal imbalances that people suffer from after having COVID, or actually also the vaccination. I'm going to be a bit controversial here, but so that's really the case. And I think we have so many questions. So I'm going to ask you, Felice, if you would consider actually doing another episode with us further on, because it's so fascinating to listen to you. And I think there's so many more things to say about this. I know we have a German gynecologist in Sweden who's been really struggling to get the Gynecology Society to understand the importance of bioidentical hormones. And it would be thrilling to actually invite her and you in an episode to discuss this, because I think you have.
And her name is?
Her name is Hilde Löfqvist,
Right.
and I've worked with her, and I think she's brilliant as well. But your knowledge, I mean, we're just gobsmacked.
Yeah,
really.
yeah. Okay, we are fighting
Well, the
here about
answer
the
is
question.
yes. The answer is yes.
Okay,
I would be happy to
thank
do
you,
that.
Thank you. I just have to ask you, as a psychotherapist, with trauma and the hormones in women. We talked about this with the gut brain and so on. What do we see after trauma? Because I've heard that after a woman has been traumatized, the hormone mirror. Do you say that in English? Hormonspegeln.
Well, the hormone balances.
Yeah, the
It can
balance.
be. Well, women more than men, not that men can't have post-traumatic stress disorder, but women are more prone to having all emotional problems except schizophrenia,
Right.
more than men do. And when you have something like an emotional trauma, it really affects the brain, especially in terms of, I know that's going to be talked about too, like the amygdala and the different areas of the hypothalamus that control all of these reproductive functions. And so emotions have a huge impact on fertility, on hormonal production and balance. So absolutely, women who have suffered emotional traumas, if they have PTSD, they are much more likely to have hormonal production problems because of that. So
Because
the
then-
body is one.
Yeah.
And, it's one of those amazing things that how emotions can absolutely impact on the hormonal production.
Right.
And of course, when you have a lot of emotions, like the gut-brain axis is bidirectional. So you could have something that starts in the brain
Right.
and it will affect the whole autonomic function of the body, which includes the gut motility and all the different functions that relate to digestive enzyme production, the gallbladder contracting. All these things are interconnected through the autonomic nervous system, which is heavily regulated through the brain because the neurological signals go back and forth, what we call
Right.
efferent and afferent. So emotional trauma can have a multitude of effects throughout the body, including the hormonal balance.
Right, and we know this through the polyvagal theory. As many speak, you might speak of it tomorrow as well. Might
A little bit.
a little bit, right?
I only have an hour.
Yeah.
Yes, and we
should have.
I think I'm going to ask another
Thank you. For that.
question about the hormonal treatment. So what's your opinion? I mean, in Sweden, we, except for the fact that we have yet to understand the importance of doing bioidentical hormonal treatment that I very much believe in, but also there's a discussion when to start treatment and when to end it. And in Sweden, we say that 5 years after menopause, you don't start it because then there's an increased risk of cardiovascular disease and that stable plaque will be unstable and so on. But also that the recommendation is that it's like 10 years treatment and then you stop. But what's your opinion in this? And
Well, I disagree with those, policies. Number one, there is actually no good human data whatsoever showing that starting hormones at any particular point post-menopause is going to increase death or heart attacks or strokes when it's bioidentical, when you're giving the estradiol transdermally. And it's like what we use the expression apples and oranges. You're comparing two different things. So the Women's Health Initiative and a prior study called the HERS study used conjugated equine estrogens, the brand name Premarin, along with the medroxyprogesterone acetate, brand name Provera. They put
Provera in
it
Sweden
together
too,
and
yeah.
they called it PremPro, okay? And when you give that combination of hormones, and they're technically endocrine disruptors. They use the word hormones, but they're not human hormones, and they have very different effects. And we now know that the medroxyprogesterone acetate was what increased a little bit, but it was still increased the incidence of breast cancer, and that the Premarin, because it increases blood clotting risk like fourfold, in someone who is unhealthy, can then trigger more blood clots. But and as you get aged, you're more prone to blood clotting because you have more inflammation. But what does that have to do with anything that we're talking about? That has nothing to do with. It's my analogy is like I have a couple. Like you do a study with trans fat, which is very bad, manufactured fat, which is really harmful and is now illegal in the U.S. And then you say, but never have like the most organic cold pressed virgin olive oil. Like they're two different things, or do a study with strawberry flavored jelly beans, and then the results show more cavities, obesity, and diabetes. So you're never to eat an organic strawberry. This is absurdity. This isn't science. You're looking at one thing and then saying that it affects the outcome of something else. And that is not logical. So as far as I am concerned, all of this data is based on the Women's Health Initiative, and that has nothing to do with what I would be prescribing, bioidentical hormones with the estrogen given through the skin in some fashion. So that's been shown that it does not increase blood clotting. It does not. In fact, estradiol is anti-blood clotting. It's like so absurd. It's oral estrogen, like when you take Premarin, or when you have the ethinyl estradiol that was in the typical birth control. It's irrelevant. And this is like what the newest data shows when you actually do the research into like what's out there, is that it's the hypothetical, and it is hypothetical risk of starting hormones has not, like in terms of like, couldn't you get a stroke or a heart attack more likely? It's not about the age of the woman. There's nothing about age per se. What does age mean? It's about the pro-inflammatory state of the woman. Now, this can happen at any age. You could have a woman who's 50, she's just in menopause, and she feels horrible. She's having horrible hot flashes, and they want to give her hormones. She's in more of a metabolic ill health than, say, a woman who's been eating the right foods and she's exercising, and she's 62. And she went into menopause 10 years earlier. Who has the higher risk here? Now, what is the risk anyway? Like, what risk are we talking about? Well, if you look at what estradiol does, it increases the production of a very vital, and it facilitates an enzyme called endothelial nitric oxide synthase, which causes,
is so important.
It's so important, and that causes the production of this incredible anti-inflammatory gas called nitric oxide. Now, if you have an incredibly pro-inflammatory state, which has nothing specific to do with age, then there is a chance, hypothetically, not shown in any clinical human studies, that you can take this process, this pathway, and you go down the wrong pathway that we call uncoupling. So instead of making this wonderful gas, nitric oxide, you end up making things like superoxide, which is 2 oxygens, which is very toxic, and some nitrogen toxic related products. And that would make, the situation potentially more unstable or inflammatory. But that's number one, hypothetical. Number two, that is not an age thing. So what I'm looking at is inflammatory markers. What's the actual metabolic state of the woman? And then making sure that if she really does have the potential for uncoupling when you put the estradiol in, that you do everything to reduce inflammation. Now, these women already have high risk. I mean, before you don't put the estrogen into them. So you want to do all these things. And then what I would do for those women is I would, just like you do with hypothyroidism, I would start low and go slowly in terms of raising the dose while I'm working on their gut health, their inflammatory status, their sleep, and all the other ancillary things that are important for healthy living and healthy bodies. So, and once again, this is really more of a hypothetical, but this is the other part that's interesting. And this, by the way, was in rat studies, because we don't have the human studies. They found that the rats who had their pretend menopause, so to speak, they had their ovaries removed. That's how they always do it in rats, pretty much, usually. Sometimes they wait till they're old-ish. But what they found was that the rats who had any increased risk or they had poor response to the estradiol for their vascular system, they had an abnormal gut microbiome. Back to the gut microbiome. It was the gut microbiome. So you work on the gut microbiome. You give them all the prebiotic foods, the probiotic foods, you work on all the things to, give them supplements to support gut health. You give them maybe, L-glutamine, you give them coating agents, like slippery elm and so on. You give them, make sure they have the right magnesiums in their body, the right nutrients, the right other like zinc and selenium. You have all the right nutrients. Thyroid is right, all the things that are important. And you work on restoring the gut microbiome to a healthier state. And there's no reason that these are the things you should be doing anyway, right? And then you can give hormones. But once again, this isn't really so much an age thing as a health thing. So, and no one says that you can't give hormones if you're 50. Even if you have, look at who they give birth control pills to with no thought.
And I think
like the highest risk women are often given birth control pills, like PCOS women who have a naturally increased pro-inflammatory state.
And they will also respond negatively.
That's
because
true.
most PCOS women are sort of almost misuse of the word, but allergic to birth control pill. They really have negative reactions to them. So, and instead of then looking into, I think the problem is with birth control pill, because today with teenagers, and they see a midwife and they go, they put the pellet. The progestin pellet,
and we have them, of course.
And they have. They get depressed, they gain weight, they feel shit.
Well, they have also like incredible rates of abnormal bleeding. It's
exactly.
And then they like look for solutions for all the bleeding.
Yeah, instead of sort of maybe use a condom. Sorry,
right.
but there are
in
condoms.
The same camp because I tell people, condoms are not the condoms of your grandfather. They're now made of materials that are modern. They're really thin. Like people actually find them in some type, like enhancing, because they're actually they actually have ones that are marketed for. You'll like sex better if you use this condom, and also not get someone pregnant or
it protects you against
STI.
venereal diseases.
Yes,
which
are epidemic. Really, oh my gosh.
So for me, I think with the youth, we should talk about, and then I think the other thing they do with young women is that they come to the doctor because of menstrual problems, and instead of trying to understand what's happening, why do you have this menorrhea? Why do you have heavy bleeding? Why is that? It's like, okay, we put you on birth control pill, and that way we sort of make the problem, and take it continuously, don't have any bleeds. And then 15, 20 years later, these young women suddenly, a little late, decide that they want to have kids, and then there's problems.
Yeah, that's correct.
We turn off the menstrual cycle for years and years and years, and then we expect it to just magically work. But anyway, going back to my question, so how long should you be on
for the duration of the woman's life? You would never say, now stop eating vegetables, or now you don't need thyroid hormone anymore, or, no, it's for the life of the woman. If once you make the leap and you believe in all of your being that hormones are essential for optimal health, you would never take them away. The problem is that leap of understanding has not happened yet. That's my mission. You got it there in a nutshell.
Right. So before we end this beautiful conversation, I'm totally starstruck sitting here. I just want to ask you, what do you think about the cancer risk of having hormone treatment? In Sweden, they are talking
as
a lot of that.
Breast cancer, they actually say that bioidentical hormone is maybe even protective.
That's right.
Yeah, but it's the endometrial cancer that they
because
use.
It's a lot of women that is really scared of having hormone treatment because of this saying.
Yeah.
And so, can we say something about that?
Well, there is now actual data showing that's not just hypothetical based on science, but actual clinical data showing a reduced incidence when you use estrogen. And they actually didn't even just show any type of estrogen. It was like all kinds of estrogen, lowered breast cancer incidence. So it's medroxyprogesterone acetate that increases breast cancer risk, but not by a lot. But still, it's a small increase, like in
but
the
it
20s.
Is an increase.
But with that, not with the estrogens.
No.
Now, if you look at just general, like, what is the mechanism? How could, like, estrogen, like estradiol, how could it increase breast cancer or any other cancer? It would not, because when you look at the way that cancer occurs, so cancer is now understood, it's a metabolic disorder. It has to do with inflammation, and you end up having these like senescent cells that are yucky old, and they have things in them called like misfolded proteins, and they should commit cell suicide. They should kill themselves. And that's what they talk about, senolytics, these compounds that tell the old, and sometimes they're called zombie cells, like kill yourselves, your bad cells. You're creating inflammation, and you're what turns into cancer. Well, estradiol, through its actions on the mitochondria, which we now understand control the cell cycle. It tells the cells when it's time to die. And the estradiol is really like the overseer of that whole function. So estradiol is essentially a senolytic. It tells yucky old cells when to die. It also is the master of creating what's called autophagy, where you have intracellular renewal, like spring cleaning of your cells. Like you take the old pieces, the organelles, and you put it in the what I call the recycle bin, the lysosome, and then you create the original particles, like the amino acids and so on, and then you reconfigure new structures. So it's like revamping inside the cell to make it like rejuvenated. That's all under the control of estradiol. In addition, when you have a lot of inflammation, you upregulate the enzyme to make estrone, which, as you had said, is like pro-inflammatory. It's like it's the alpha receptor, which is what's activated by estrone, is the dominant receptor on the innate immune cells, like the original attack cells, like the mast cells, macrophages, neutrophils. And so it kind of activates them like the on switch, but you don't have the off switch because you don't have the beta. That's like more the off switch. So you end up in a pro-inflammatory state, and inflammation causes DNA instability and breakage. So that can be more pro-cancer, but that has nothing to do with estradiol, and this is due to inflammation. Estradiol is anti-inflammatory along with progesterone, so it would be anti-cancer when you have proper ongoing beautiful hormones in the body. And then when you look at cancer like breast cancer, what causes it to metastasize is the lack of the cohesiveness of the cells of the cancer. So it turns out that estradiol helps to increase cohesiveness. So it's like they're glued together so they don't break off and then travel through the lymphatics or the blood, the blood vessels to distant sites. That's why when women are actually diagnosed with breast cancer and they're on hormones, they have a lower mortality rate because their breast cancer is less likely to have metastasized. So there's a host of ways that estradiol maintains proper immune status. So it's anti-cancer. And it's like so nutty. This whole thing, like your own natural hormones were put in your body. And who tends to get more cancer? Old people or young people?
Old.
Yes, and they're the ones that don't have the hormones. I know. And the ones who are young that are getting cancer, which is increasing, is horrible. It's because they have altered gut microbiomes from C-sections and antibiotics and all that's going, and the endocrine disruptors. It's not because they have hormones, it's because the whole fundamental systems of the body have been interfered with by all these like modern day things that are happening in our world, not because they have hormones, it's in spite of hormones. So I think we need to rethink everything about this cancer fear from hormones. It's anti-cancer.
That's
it's
why I wanted
anti-cancer.
It's anti-cancer. We say that, all of us.
Yay!
And that's why it's called the hormone of life, as you started this conversation.
It's the hormones of life. For And it's of life and it's for life.
Right. It's so beautiful. And this is, so that's why I asked you, because I really want to put this out for our listeners, that they should really consider hormone treatment and not be so scared about it. Because if you see a woman that don't get hormone treatment and really, really needs it, it's not a good.
No, but I mean, it also has a lot of metabolic consequences that actually increases cancer risk. And I think Hilde, this gynecologist that I talked about, said it. She said, 1 in 10 women will have breast cancer in Sweden. That's our incidence
we say
number.
It's 1 in 8 in the U.S.
Yeah, so 1 in 10. But it's not going to be because of estradiol. It's going to be because of smoking, because of alcohol, because of bad food.
You know what the biggest
stress,
menopausal risk factor is for breast cancer?
No.
Obesity and weight gain. Yeah.
So that is also very important for the listeners to hear that.
And what helps to prevent it? Estradiol.
And a good microbiome.
Well, absolutely. They all go together.
Yeah,
it's the total package of health. Right.
So we are so honored to have you in this pod, in this episode. And I also say thank you very much, Sharam. You came to us with the tea and some oat milk and participate in a beautiful way. And Cecilia, to bring this wonderful doctor that we're also going to listen to tomorrow, and looking forward to have the episode 2 after. I hope you have time for us after that.
Yeah, and we can do it digitally, maybe.
Oh, okay.
We might have to.
Mm-hmm.
All right. So digitally we do it. And thank you so much to participate in this conversation.
Well, we're all literally on the same team.
Yeah, we are.
To help women.
Yeah, we are. Okay. So thank you all.
Både och istället för antingen eller, en podd om integrativ medicin och hälsa är skapad och drivs av Svensk förening för integrativ medicin och hälsa, FIM. FIM är ursprungligen en yrkesförening för legitimerad vårdpersonal. Vi representerar sjuksköterskor, dietister, fysioterapeuter, läkare, psykoterapeuter, psykologer, tandläkare för att nämna några. Idag omfattas våra medlemmar även av associerade medlemmar som inte behöver vara legitimerade. Föreningens arbete vilar mot en vetenskaplig grund för integrativ medicin och hälsa, såväl svensk som internationell, och på systemisk förståelse för människan i sin miljö. Föreningens arbetssätt har hittills varit att arrangera konferenser, seminarier och folkbilda genom att sprida information, exempelvis via sociala medier. Vår strävan inom integrativ medicin och hälsa är att vara en organisation som vågar lyfta och ifrågasätta, motverka polariseringar genom tvärvetenskapliga dialoger och sokratiska samtalsregler. Vi vill kartlägga forskning som bedrivs även internationellt och hålla koll på forskningsresultat om behandlingsmetoder, både vad det gäller den etablerade vården liksom den vård som bedrivs utanför den etablerade vården. Sokratiska samtalsregler innefattas i den sokratiska samtalsformen som egentligen all grundläggande kunskap är sprungen ur, men som ibland till och med lyser med sin frånvaro inom public service. Så bli gärna medlem hos oss, för tillsammans kan vi förändra. Och hur du blir medlem hittar du via vår hemsida integrativ-medicin.se. Vi ses och hörs i nästa avsnitt.